Thank you. There are three parts: non-solid, part solid, and solid. I cannot tell the difference between the non-solid and part solid. I maybe, I talk more about you. There are no conflict of interest to disclose for this topic. All the big famous lung cancer screening, they found about 58% of stage 1 lung cancer. So that reduced the mortality of the lung cancer in the population. So there are two studies I did to show in China, and we found that they're much different from the Western society, young female non-smoker, and the GGO part. The first about a high-risk population, 70% in the stage 80% in stage 1, 70% a GGO type line of carcinoma. Another one, 97% is stage 1 and 96% is GGO. So the more detection of early stage lung cancer, the low mortality of population. Is that true? If that's true, we need to find more and more stage 1 lung cancer patients in the population. So what's the GGO, non-solid, the sub-solid, part solid, there's inflammation or benign disease, and other is from atypical hyperplasia to invasive adenocarcinoma. How to improve the diagnosis accuracy is very important for us. We can see that, the GGO in 10 years, they're very slowly growing for 10 years. Once, the solid component come up, it will progress very quickly. In 15 years, it turned to be invasive adenocarcinoma. We can go back, what the ideal time for us to deal with this kind of patient. This is the one I operated on is 38 years old female. There's only one, crossed the 3 years, but only, totally less than 1.5 years. From the small mixed GGO to a solid, within 2 years, we operate on the patient with adenocarcinoma invasive. It progressed very quickly. Another one, from less than 7 years, from operable, curable stage 2, stage 4. And they warning us we need to catch the point we can cure the patient, not until the patient in the stage 4 treated under the drug. In the 2020, patient in the stage 4, we biopsy patient harbor EGFR mutation. The patient still have the opportunity to survive another 5 years with, under the price of the drug. But the patient suffer, cost a lot of money. If we action earlier, maybe we can cure the patient without any drug, without it suffer after the surgery. So how can we actually diagnose it for the patient? Keep one sentence in mind. For the GGO, persistent, slowly growing, turn out to be 95 malignant. We cannot 100% for sure, but keep that persistent. Some GGO, they can disappear. And persistent, slowly growing. That's slowly, not in terms of week, month, in terms of year. So it's slowly growing, turn out to be 95% malignant. So what's the relationship between the imaging and the pathology? I think there are 3 studies. One study, JCAL 0201, and it published and done by the Japanese colleague. The subgroup analysis, they defined the CTR less than 0.5 and 2 centimeter less, define non-invasive. That's according to 3rd edition of WHO classification of lung cancer. The second study is I-ELCAP 1008, done by us, last sentence, over 600 patients, the accurate prediction lung cancer is over 95%. How can we predict the invasiveness? If less than 1 centimeter, we predict the AISMIA accurate rate over 97%. Greater than 2 centimeter, we predicted invasiveness is not over 97%. But unfortunately, between 1 or 2%, the accurate rate dropped to 70%. And how we did another study, EasyTop 11, the correlation between the whole section radiology and pathology. We found that, in mixed GGO, the pathology invasive component tend to be underestimated radiologically. In pure GGO, acina or papillary subtype may be present, but micropapillary or solid subtype are absent. In mixed GGO, the micropapillary subtype exists within the GGO component, while micropapillary solid subtype exists within the radiological solid component. So I think this is the only study published to explain the correlationship between the imaging and the pathology. So how can we do for the, for the imaging like this? Nobody doubted we need action. We needed to do a lot of things. A lot of before surgery workup, and after surgery, maybe the imaging like this maybe turn out to be stage 1 or stage 4. After we do a lot of things. But like this, actionable or non-actionable? It's a big question, the big debate. Maybe, it's overdiagnosis, overtreatment. A lot of things that I'm talking about. If I talk to you, this is the same patient, 2 patients, and different from 6 years or 15 years. So in different years, what do you think? What's the ideal time for your action? So here is an invasive or non-invasive procedure. Surgery, most think that's the invasive. Non-invasive radiotherapy, ablation. So no evidence of randomized trial to directly compare the surgery to any of them. And for the palliative treatment purpose, maybe yes. Radiotherapy ablation is truly non-invasive, I'm doubted. So for GGO type lung adenocarcinoma, we did a lot of study to define this is special clinical subtype. And also we, from our study and the Japanese study, we can also show that, there are 5 years, 10 years RFF, 100%. But we need to look at, in Japanese group, they are earlier than us, 50, at that time, over 50%, even for the AISMI, they do the lobectomy. I think that's over-treatment. And in our data, about over 1/3, still the over-treatment. For pure GGO, they're including the invasive adenocarcinoma, 10-year survival rate, RFF rate, and 100%. So we cannot operate, biopsy the patient from AH to minimum invasive MIA to the stage 1 to 4, but we collect over 1,000 pair of tissue from AH to the stage 4. It's a complete clinical radiological and pathological information for all the patients. It's a paired tissue, we do WGS and yarn-seq. And the GGO type from pure to mixed to solid. And we can see that, from the beginning, so they're genomic, they're the cancer. The only difference is the degree, maybe the tumor surprise gene mutation in the very early is low, but in the stage 4, it's very high. So for the gene mutation from the beginning, almost the same. So we call that it's a special stage for the GGO type. If it live there for long enough, they will become to kill you. So the pure GGO ASMIA, it's 5 years, 5 years or 10 years, so RFS 100%. Some of the other type of lung adenocarcinoma may not be cured, but you cannot predict individually. Once the curative time window is missed, the tumor might progress to the lung cancer. That means we know the lung cancer will kill you. So we need to seize the curative time window. So we create the concept, curative time window. That means 100% for sure. You operate on this time, patient can RFS 100%. So we are talking about the over-diagnosis, over-treatment. What that means. So how to avoid that? Persistent and slowly growing. We keep the bar high enough for the benign rate, very low enough. So we need to examine the life expectancy versus natural history. If life expectancy is greater than the natural cause, we need to operate. We need action. That's not overdiagnosis and overtreatment. Otherwise, the patient expectancy life is very short. The natural history, natural cause were long enough. We don't do anything. So that's the expertise review we published several years ago in the seminar GTCS to avoid something that's a principle. And also we call minimally invasive surgery. That's what we are talking about, Uniport. So radiation oncology, you are talking about a minimally invasive, where no incision. So we are no invasive. That's what I call no. That's radiation still have an invasive. Minimally invasive, just not minimally incision. So we propose the minimally invasive 3.0. Minimally incision, minimal resection, that's the key. You keep the lung parenchyma as much as possible and keep the normal lymph nodes there as many as possible and minimal systemic damage. We keep our patient longer and better, not just incision smaller. So we do a lot of study for the GGO type. We work before surgery workup is very, very simple. And also selective mediastinal lymph node, we make that conception. And also we published the expertise review in JTO 2 years ago. And we do a prospective study, is the phase 2, there are 6 preconditions to predict the lymph node negative that's published in the JTO 2 years ago. And last year we published the phase 3 trial to compare lymph node dissection and without lymph node dissection. So regarding the RFS OS, it's the same, but perioperative operation is much lower in non-dissection group. So the JCO accompanied the editorial. I think they will change it, clinical practice in the near future. And also for the post-operation civilian, for the GGO type, within 6 months you can have 1 CAT scan. Otherwise, you can patient to come back, 2 or 5 years later. So it's more individualized follow-up strategy for different patients. And also, this is what I published expertise review in JDCVS in last year. There's the milestone from 1913 to 2023. That the big change toward more individualized surgery procedure, and that's we call even in the stage 1. Now, one feed-out procedure is gone. The more individualized, and also the mediastinal lymph node dissection strategy also in the near future will come to our clinical practice. And you can see, from the different, maybe in the 2014 before the lesion you found it, You can do one resection, cure the patient. Or you wait to segmentectomy, wait for the lobectomy, wait for no surgery. Just biopsy, give some drug. What the proper time for you to action? I think that our workflow for the whole system, and why we still found even the screening so popular, we still found patient in the advanced stage. So we found that the over screening and under screening coexisted in our clinical practice. Because of time, I cannot explain what the over screening and under screening.
1 minute,
This
Dr.
is
Chen.
our time. I think within 2 months, this is artificial review will publish in the JTCVS. So we can see catch the point for cure, and from stage 1 to stage 3, we improved survival. For the stage 3B to 4, that's medical oncologists, radiation oncologists. They try to make this patient become clinical practice. Thank you for your attention.